Good evening, friends. Welcome back to our prestigious Otology Ninja program, 29th class of Otology Ninja program. Today, the class is about middle cranial force approaches, and we have a surprise, a distinguished guest today, Professor Dr. Ravi Samy from University of Cincinnati, USA, a old friend. And the moment I messaged him once, he immediately, he honored us by agreeing to be speaker on this. He visited long back, I don't know how many years, 7, 8 years back, my place, Chitradurga. He was a speaker in my medical college, and today he is honoring us with his talk. And I'm sure he's going to again back with us in future also with a lot of his experience in different aspects of otology, pediatric and adult otology. And today we have moderators as Professor Dr. Balakrishna from the thing KMC Manipal. Again, one of the most very well accomplished person, rather I would say, and a good friend. Whenever you call him, he's always available for any help. And I'm telling you, a man who comes with vast knowledge, base of knowledge. And Dr. Kumaresh Krishnamoorthy, another great friend of mine from Bangalore. I would look at him, rather than a entrepreneur, medpreneur, than a otorhinolaryngologist. Okay, he's both of them. I'm telling you, he has lot of innovations to his credit. For example, right now, to help us with this COVID-19 situation, he has come up with his UV radiation, some sterilization equipments that he has been, he will speak sometime. He will also share some of this experience with us. With this, I request Dr. Kumaresh Krishnamurthy to introduce Dr. Ravi, because Kumaresh and Ravi, their friendship goes a long way back. We could see that camaraderie. Could observe that they worked together for some time at US. So I think Dr. Kumaresh Krishnamurthy will be able to speak better about Dr. Ravi. Yes, Dr. Kumaresh.
Sure. Thank you, Praglad, and good evening, everyone. It's a pleasure and honor to introduce Dr. Samy. He was my mentor, guide, and now he's a very close friend of mine. And I look up to him for, when I started my practice here, whenever I had a doubt, I used to call him and we used to, discuss it. I was his very first fellow in the US. Dr. Samy did his administration at Stanford, and then he did it at Iowa under Dr. Vance. Then we had a short stint at Dallas, University of Southwestern. From there, we moved to University of Cincinnati, and those were good times, because we both were new to the setup, and I was finding it difficult to adjust to the culture and things like that, and he was helping out. Those were golden times, and now Dr. Samy is the program director of the Otology Neurotology Fellowship. He's a director of the adult cochlear implant and skull-based surgery, and he has got his own lab. And we both have done a lot of innovative papers over there. And now Dr. Samy has even done probably the second auditory brainstem implant in the US mainland. And his special interest is in cochlear implants and skull base, and he's planning to venture into robotic surgeries. So with this, I don't want to take much of a time. I will pass on the mic to Dr. Samy to start the topic of the day.
Yeah.
Thank you, Kumaresh. I'm going to share the screen.
Yes.
Can everyone see that okay?
Yeah, that's fine. Perfect.
Wonderful.
You're good to go.
It really is a pleasure and honor to be here, and I appreciate Kumaresh's kind words and Prahlad as well. I think when you are a fellowship director, one of the things to think about is, especially when you're starting a brand new fellowship, is you have a lot of pressure on you as the program director to make sure your fellow has a wonderful education. And so thank you, Kumaresh, for being willing to take a chance on me when the fellowship first started. And it's neat to see over the last 15 years how the fellowship has continued to grow. But as Kumaresh always says to me, he says, don't forget, Dr. Samy, I'm always the first. So yes, he's always the first. All right, and feel free to email me. My email is at the bottom of the screen. We'll talk about both standard and extended middle cranial fossa approaches. Someone said they can't hear. It says no sound at their end. You can hear me okay, correct?
Yeah, we can hear you.
Okay, good. So I'm going to start off with this slide. This is a quote from George Merck, who was founder of Merck Pharmaceuticals. He said, "We tried never to forget that medicine is for the people. It is not for the profits. The profits follow, and if we remember that, they have never failed to appear." So we are truly all blessed to be physicians and surgeons. And, you know, what's a challenge in the U.S., and I'm sure in your own way in India and throughout the world, every medical system has challenges, is that a lot of times, especially when you're dealing with business people, the cart is put in front of the horse, and we look at the profits first, and it should be the other way around. Always look at each person, each patient, as if that was your friend or family member, and you will never have an empty waiting room. And this slide shows a lot of different people here from the top left. Let me see if I can use my, if there's a way to use my mouse. Okay. So upper left-hand side is Dr. Bruce Gantz and Jay Rubenstein. They're my mentors at Iowa. And so my passion for the middle fossa approach really came from the two gentlemen, especially Dr. Gantz, who just stepped down as chair at Iowa. And then next to about the 1 o'clock, 2 o'clock position are Dr. Miles Penzak and Dr. Mario Zuccarello. And they have been mentors to me, as well as Dr. Andrews, who's shown here on the bottom left. While I learned a lot about the middle fossa approach, the standard approach from Dr. Gantz, how to deal with acoustic neuroma, superior canal dehiscence, CSF leaks, I think collaborating with neurosurgery has really changed how I view the skull base, because what they deal with as neurosurgeons, their pathology can be complementary but quite different to what we do as otologists and neurologists. So, for example, brainstem cavernomas, basilar artery aneurysms, neurologists don't think of things such as that. But it was wonderful to work with them to expand my understanding of the skull base. And then we have the next generation. We have Jonathan Forbes, Noga Lipschitz, who just finished fellowship with us. She's in the middle, bottom. And then Scott Shapiro, my current fellow, Ali Maines is nurse practitioner. You cannot do world-class skull-based surgery without a world-class team. So we are very blessed and fortunate with our teammates. So I like showing this slide because people often, especially the residents of today, the med students of today, don't look at our predecessors. We stand on the shoulders of giants. So on the left there is Bill House, and on the right is Bill Hitzelberger. And the two Dr. Bills, as they were known, a House Ear Clinic, really were impressive in terms of what they did as collaborators. And they each brought a unique skill set. So if you look at modern neurotology, everyone calls Bill House the father of modern neurotology. Not only was he involved and instrumental in creating the cochlear implant, the auditory brainstem implant, but the middle fossa approach, translabyrinthine approach, facial recess, but he couldn't have done that without Dr. Hitzelberger. And when you look at some of the literature, and Prahlad, there's some background noise. I don't know if you're able to mute other microphones, but I heard some background noise. Thank you. But if you look at what the time, like to this day, while I enjoyed the middle fossa approach, and it's my favorite skull-based approach, I still find it challenging depending on the pathology. And Bill House's first middle fossa approach was in 1959. And it's hard to fathom that 60 years ago, he was doing what he did without the technology, without the microscope quality, without intraoperative nerve monitoring. And he initially thought that by decompressing the cochlear nerve, he could help in cochlear otosclerosis. So that was his initial thought. So he did it for the wrong reasons, but then he quickly realized you could use the middle fossa approach for vestibular nerve sections. You could use it for tumors, of course, and a whole host of other conditions, and we'll cover those today. So I think what keeps our organization sharp is working together on different aspects of the middle fossa approach. So for example, our leak rate has been the lowest with the middle fossa approach as opposed to other approaches to the skull base, retrosigmoid and translabyrinthine approach. And that's due to the fact that the temporal lobe, you can see all opened air cells on the middle fossa floor directly in view. And then you place tissue on the middle fossa floor, followed by allowing the temporal lobe to re-expand on the middle fossa floor. So that's one of the things I've liked about it. And it's interesting, the ultrasonic bone aspirator, I have a couple of slides up front or in a few minutes, but actually Kumaresh is the very first person that I used the bone aspirator on. It's called the Sonopet, and we used it on cadaveric models for facial nerve decompression. And I was taught how to use that by Dr. Zuccarello because of the neurosurgical team. And it goes back to the cross-fertilization and learning from them. And so these are some of the other papers, from audiometric outcomes to our decade of experience with the middle fossa approach. So these are slides from Rob Jackler's textbook, Atlas of Neurotology and Skull-Based Surgery. You can actually find these online. And Alex Carcass, who's a dear friend of mine, and he's in Saint Etienne, France, near Lyon. He and I have given talks at the European Association of Neurotology. So some of these slides are from Alex's talk. But if you look here, the incision on the left-hand side can be a variety of different incisions. Some people, including the house group, and they may still be doing this, use a preauricular incision. I tend to use what Ugo Fish had taught Dr. Gantz, which is a posteriorly based skin flap with a limb that goes behind the ear. You can use a variety of incisions. Then the craniotomy is done, and the neurosurgeons typically use a craniotome. I use a drill just because I'm so familiar with the drill. This middle diagram shows how when you're doing that, you need to make sure you avoid air cells near the mastoid. And the goal is to elevate that bone flap off the dura and look at all areas and not allow it to be torn, which can happen very easily, especially as patients are older or get older, the dura is thin. So these are some slides, excuse me. These are also some slides. You can get this from the University of Iowa head and neck protocols. I would say 75 to 80% of what I still do from a skull-based standpoint, I learned from Dr. Gantz. So a lot of the middle fossa, as you can see here, the skin incision is what I learned from him, and I still tend to use this same incision. And then you can see an electrode in the ear canal, and that's for the ABR click generator. So the challenge with the middle fossa floor is what you see here. So the diagram on the left, you don't have much anatomy to start off with. The posterior extent, when you see the blade of the middle fossa retractor, you'll see the petrous ridge, you'll see superior petrosal sinus, GSPN, foramen spinosum, but the ghosting of the images on the right-hand side is what you're trying to achieve. And so this is where angels fear to tread. This is where you have to be very careful, because if we're doing a hearing preservation surgery and we don't know our anatomy well, then we risk getting into the cochlea and causing deafness. And yet what we're trying to do is prevent that, or you can cause injury to the labyrinthine segment of the facial nerve. And this is in the middle bottom is one of the images of Dr. Carcass's patient who did the middle fossa approach on for Bell's palsy, or he'll use that same approach for traumatic facial nerve disruptions. So there's a variety of methods to find the intra-auditory canal. So the original method that Bill House described was to follow GSPN to geniculate ganglion to labyrinthine segment, and that leads you into auditory canal. And I have to tell you, when I first started the middle fossa approach, this was actually incredibly hard for me to do. And I now use that much more regularly, but early on, it was very scary to think you're about a millimeter away from getting into the cochlea and deafening someone. So I actually don't like the House method for teaching my fellows. And so I use the Ugo Fish method, which is he'll first blue line the superior canal. You can see that on the bottom right. And then he will work 45 degrees from that after blue line in the canal. The canal is always going to be perpendicular to the petrous ridge. Then it gives you a nice view of the intra-auditory canal, and you know where the IAC should be. Now, that's not the only way to do it. A lot of people use the Jackler method. And with the Jackler method, Rob Jackler would work medial until he saw what he thought was maybe petrous apex air cells to intra-auditory canal, and then worked out laterally. What's very helpful, by the way, was when someone's first doing the middle fossa approaches, and it's still helpful to me to this day, is having a CT scan. So while we use the MRI scan, of course, for finding an intra-auditory canal lesion, The middle fossa floor anatomy and pneumatization patterns are best shown with a CT scan. And then the Garcia-Ibanez method is to dissect the arcuate eminence and greater petrosal nerve. So I think having a variety of techniques in your armamentarium allows you to do the best job possible to really define the intra-aortic canal. So this is from Mario Sana's textbook. This is the left middle fossa floor. He has some beautiful dissections in his textbook. And you can see the middle fossa dura marked by MFD, arcuate eminence. And one of the dangers of the arcuate eminence is the highest point on the middle fossa floor is not always the superior semicircular canal. About 15 to 20% of time is another structure. It could be just the pneumatization pattern. So that's why Fish described blue line and superior canal first. If you see some of the dissection in this diagram, which are beautifully done by Professor Sana, you'll see decompression of the IAC, and you can actually see decompression of the posterior fossa dura marked by PFD. C is for cochlea, GPN for greater superficial petrosal nerve. So what we've done at our institution is really expanded the middle fossa approach into posterior fossa pathology, as well as pathology to the ventral brainstem by really removing a lot of this bone. Seeing the IAC contents and getting rid of the bone improves the neurosurgeon's ability to access the pathology, and it makes it so they can pull on the IAC contents if they need to pull it or push it anteriorly or posteriorly without detriment to any of the neurovascular contents. So you can actually see once you open up the dura posterior to the IAC, you're actually looking into the posterior fossa. So that's allowed us to get larger IAC CPA tumors as an example. So when you're doing other pathology along the middle fossa floor, regardless of what you do, the facial nerve is key. It is critical. What I've noticed when I teach residents is, for example, on just standard mastoid approaches, especially when they're early on in their career, they're fearful of the facial nerve because they don't want to transect the facial nerve. However, there's a quote attributed to Bill House, "Find the facial nerve before it finds you." And that is a good thought, because if you know where the facial nerve is, you can use it to guide you to where you need to go. So on the left-hand side, you see geniculate ganglion, again, GSPN, cochlea, IAC, arcuate eminence. And one of the things that I think would be good for us to do in our lab, Dr. Andaluz and I and our team has a wonderful skull-based lab. I don't know if this has been described before, but one of the things I've used is the fact that the arcuate eminence, or the superior canal itself, the blue line canal, points directly to the malleus. And that distance is probably about 5 millimeters. I'm not sure exactly, but what it allows me to do is if I know where arcuate eminence is, or superior canal blue line is, then I can actually tell you where malleus is, and vice versa. And I think that has been a very good thing for me to be able to use to know from above. You can see incus and malleus, and you can see tympanic segment of the facial nerve with this dissection. So from Dr. Gantz's slides from the Iowa protocols, you can see here, this is not a 3D image, but if you look at the instrument showing you where the blue line is, to your left, you'll actually see that the superior canal is quite a bit lower than the rest of the tegmen mastoideum. And so that's why it's important to find the blue line. The other thing I do is why the blue line is so important to me of the superior canal is I actually get very close to the superior canal. That allows me to remove a lot of bone. I have to be careful about getting into the ampulated end, the superior semicircular canal. But otherwise, I have the ability to really decompress that area and take care of tumors that are now in the CPA and not just the IAC alone. So this is after the blue lining is done. You can see the hints of the intra-auditory canal within the bone of the IAC, and there's some bone exposed anterior and posterior to it. So now what I typically do is, as opposed to these images, I'm much more aggressive about removing bone from posterior, as well as into quasi space. Once again, giving you access and not being hindered by bone that's present. So this is for example, decompression here. Let's pretend, and this may be someone who's had Bell's palsy. So you can see IAC. You see the circle showing you the blue line, the superior semicircular canal. And then for Bell's palsy, we'll decompress the labyrinthine segment of the facial nerve, geniculate, and then you can see proximal tympanic segment, and then malleus. And so continuing on the dissection, you can start seeing some of the posterior fossa dura and the retractor blade. Now, one of the things I've changed over the years is the retractor blade is a challenge. The middle fossa retractor is, I think, the best retractor to get to intra-arterial canal pathology. The problem is it's a rigid retractor that has a high profile. So learning how to work your hands around the retractor is not easy for fellows. It's something that they have to spend a lot of time doing and getting used to. So now what I do is, after I've done all my bone work and removed bone to show posterior fossa dura, removed bone in the quasi space, I then open the intra-arterial canal or into the posterior fossa dura and allow egress of CSF. And once that allows the brain to relax more, I then pull out the retractor blade. And so now it frees my hands and improves my ability to work into the IAC and CPA. So this is more of a diagram showing you, this is a right angle pick. And you can see on the anterior, to the right of the right angle pick is the facial nerve, posterior superior vestibular nerve. And you can actually see we're looking into the posterior fossa. So you can see that's actually some tumor emanating off superior vestibular nerve in the posterior fossa. So if you look at the standard middle fossa approach, and depending on who's writing in the literature, you know, there are some centers, I would say in the US, are probably about 5 centers, including ours, that do a lot of middle fossa work. But a lot of other places tend to be much more retrosigmoid heavy or translabyrinthine heavy. But for the standard middle fossa approach, is what a lot of people do. You can do that for pathology within the bone. It can be extradural work, such as superior canal dehiscence repair, or it can be intradural with a stage 1 acoustic, facial palsy, petrous apex lesions, vestibular nerve work. All of that is perfectly fine. The CSF leaks, none of that requires really extended middle fossa approach. And so diagrams of this, you can see on the upper left-hand corner there is an encephalocele. You see a view, Poschel's view of superior canal dehiscence. You can see someone on the bottom left who's had intra-arterial canal tumor, and then bottom right is someone who has Bell's palsy. The standard approach will work perfectly for that. So Sean Stevens, who is one of my former fellows, he's now at Barrow Neurological Institute. Very bright young man and wonderful skill set, great surgical hands. He did some work in our lab to look at how we are better able to look into the posterior fossa. So he took cadaveric heads and had imaging done on a CT scanner before and after dissections. And he's basically showing that typically for a standard approach, let's say for sake of argument, the average amount of dissection behind the intra-arterial canal is 4.5 millimeters. If you increase that by another 3 millimeters, you know, the old saying in otology is every millimeter counts. And I would tell you that is also the same for neurotology and skull-base surgery. Every millimeter that we gain improves access to the posterior fossa on these lesions. So that allows you not only to improve the amount of light that enters the CPA, but also allows your hands to work on the CPA much better. And that can be a challenge because, God forbid, you get into a lot of bleeding. If you can't work in that area safely and consistently, then you risk causing significant trauma to patients. So Sean looked at some of our bones, and for example, here's a patient with an 18 millimeter tumor, and these larger tumors are not easy to do, definitely by a standard middle fossa approach. And he said if you did the extended approach, you have a significant improvement in the volume of bone removed. And as you can see on the graphs, it's statistically significant and allows you to work in that area much easier, much safer. So we looked at our outcomes for intermediate size tumors via middle fossa approach. 16 patients had extended middle fossa for intermediate size tumors from 12 to 20 millimeters. Gross total resection, 93%. One was near total. Hausbrachen 1 or 2 and 15 of 16. Serviceable hearing preservation, 38%. But this is what I think is important. 62% have some hearing preservation. So if you go back to the American Academy of Otolaryngology scale for hearing, or Gardner-Robertson, historically people would say that if your hearing is worse than pure tone average 50 dB, worse discrimination score than 50%, that was not a serviceable ear. And I completely disagree with that. That is all data from the late 80s and 90s, and that really pre-exists single-sided deafness cochlear implantation. So I've got a very large volume of patients who've undergone single-sided deafness cochlear implantation. A lot of Europeans are doing that as well. We have FDA approval to do that with the MED-PRENEUR cochlear implant. So I now have some patients where we're able to save the nerve and cochlear blood supply by either the retrosigmoid approach or the middle fossa approach. And almost 2/3 of these patients, by saving that, allows me to then rehabilitate the hearing loss with a cochlear implant as an option. Doesn't mean that's what they have to have. Some of these patients are okay with observation alone. Some want a standard hearing aid, cross hearing aid, Baha. There are other options, of course, available. But I'm going to publish our data in the next couple of years, hopefully, on our success rates for patients with single-sided deafness implantation after prior acoustic removal. So when you look at the retractors for the middle fossa approach, the one on the left is original House Urban design. Jack Urban worked with Bill House and Howard House. The downside about that retractor is it doesn't have as many degrees of freedom as the Fish retractor, and I use that one now. I learned to use the House Urban before, and I think Rob Jackler has his own middle fossa retractor as well. When I'm doing work with Dr. Andaluz or Dr. Zuccarello, and since their pathology can be very different, they can have large epidermoids and other pathology that I have to think that the standard middle fossa approach won't work for. We'll use retractors, Bloody Halo, there's Greenberg retractor, Layla retractor, other retractors that are around. And you have to get comfortable as a skull-based surgeon working as a team and work with the neurosurgical team and using what's best and what's available. Now, of course, we are not anywhere near being the first group that's talked about the middle fossa approach for a variety of pathology. In fact, some of the earliest middle fossa work, believe it or not, was done in the late 1800s, 1890s, if I remember correctly. And it's interesting to see that people are doing some of these approaches. Back then, though, of course, no surgical microscope, didn't have the understanding of anatomy that we do now. And so Kawase, back in '85, published the series, I believe, of 4 patients and described the Kawase's approach for basilar artery aneurysms. And you can see the anatomy. You can see the diagram on the left. You can see trigeminal nerve on the upper right, and then what the anatomy would look like if you cut tentorium and see what's available below. All right, so I don't remember where I received this slide from, but this is a very good slide to show you how much bone you can actually remove on the middle fossa. So Dr. Andaluz and I had a gentleman last week that we did an extended middle fossa on. It was a petroclival malignancy, it's poorly differentiated squamous cell carcinoma. So for him, because that tumor will take his life if we did not do something surgical and or radiation. So we were very happy we did. Our hope is, you know, only leaving microscopic disease behind, but we basically, it was a left side. On that case, sacrifice, he was already having facial palsy. He was having hearing loss. He was having dizziness. And because it's a malignancy and not a benign tumor, I drilled through the cochlea and drilled around the petrous carotid. And you can see there's a lot of bone, sacrifice middle meningeal artery. And you can see V3 going through foramen ovale. So removing all that bone medial to carotid, working posteriorly to intra-arterial canal, that is quite a bit of bone. And then there are cases where we've actually done this from above. We've actually done the middle fossa approach with a labyrinthectomy for pathology that may need access all along the middle fossa floor. So it tells you there's actually a lot of bone that can be removed here. And the nice thing is, especially for pathology antral to the or ventral to the brainstem, what you can see is that the reach to that portion is easier than the standard labyrinthine or retrosigmoid approach. The reach is much greater in those cases. So I think this can be, for those that become familiar with a a wonderful approach. So the ultrasonic aspirator, and Kumaresh is actually going, here we go, back in time. Kumaresh was on that 2007 article. So we actually did middle fossa labyrinthine segment decompression for example, Bell's palsy, all in the cadaver. This tool has been amazing. Justin Gala published with us, another star fellow of ours. Justin is at Columbia University. Justin showed that we have less bone dust creation with the retrosigmoid route than with the drill. And so the thought is, since the sonopet allows you to suction the bone right away, that we create less bone dust and may reduce the risk of headache with the retrosigmoid approach. I think this has been one of the nicest tools added. I use the drill for high-speed bone removal, for a lot of bone removal, but the sonopet is wonderful to work around corners. The drill can be fatiguing if you use it for long periods of time. For those of you that do skull-based approaches, for example, with labyrinthectomy by translabyrinthine approach. So it's nice to be able to have this tool, especially for teaching fellows. When a fellow first does a middle fossa approach, it's very scary because it's not something they're used to. Standard otolaryngology residency allows you to understand the translabyrinthine approach very easily, but the middle fossa approach in particular is the hardest one for my fellows to learn. So in Dr. Zuccarello and Dr. Andaluz's lab, we had a nice young lady who visited from Brazil, if I remember, and she did 10 temporal craniotomies, 5 whole heads, and we divided the petrosectomy into different portions: anterior petrosectomy, Kwassi's approach, standard middle fossa, IAC alone, partial posterior petrosectomy is the bone behind the IAC, and then we call the middle fossa L labyrinthectomy extension. And so brain lab was used along with frameless stereotactic CT and quantify the amount of bone that was removed. And so we basically, you can see the blue diagram here showing you, depending on the amount of bone that was removed, where all we took the bone. So if we go from anterior to posterior, so just removing the amount of bone, and by Kwassi's approach, the average removed 1.3 cubic centimeters of bone. That increased the mean working area by almost 25 square millimeters. If you then roof the IAC as well, you add another 0.3 cubic centimeters of bone, which doesn't sound like a lot of bone removal, but it increases the working area to almost 33 square millimeters. If you add the posterior petrosectomy behind the intra-arterial canal, the mean bone removal is 4.3 cubic centimeters. Working area is increased to 67 square millimeters, and you can see the green tells you how much bone that was removed there. And then finally, when you look at adding a labyrinthectomy from above, you can, the bone removal is 7.1 cubic centimeters. Final working area is almost 82 square centimeters. So I'm going to show you one more slide. And this is after our research fellow did this, the amount of bone that was removed. You can see all the way from cranial nerve 3. And there was a case that Dr. Zuccarello and I had where we looked all the way down to foramen magnum. So it's impressive by this approach, the amount of bone removal and the amount of working area. So it tells you for the right pathology, this is actually a very usable approach. So indications, basilar artery aneurysms on the upper left, to brainstem cavernoma, petroclival meningiomas, and the bottom right is a case I did with Dr. Andaluz, which is a large epidermoid cyst on a lady from Kentucky who is a teacher, and you can see basilar artery in the middle of that. So, you know, these patients have pathologies that are very unique and very special and not commonplace. So once again, having this approach is great for patients like this. Now, this is one of my favorite cases to discuss and describe. This is a patient with neurofibromatosis type 2, NF2. And this patient has had surgery elsewhere. She had a subtotal resection, translabyrinthine approach, and then she has multiple tumors. So the upper left-hand side slide shows the acoustic. Below that, she also has lower cranial nerve schwannomas. And this lady is approximately 40 years old. She is blind. She is deaf. She has balance disorders, of course, because she has both vestibular nerves gone because of tumors. She comes in with her aunt, and she has to communicate by finger spelling. And The right sigmoid sinus is the only functional sigmoid sinus. So our worry was if we did a retrosigmoid approach or another translabyrinthine approach, if unfortunately we inadvertently injure the sigmoid sinus, that puts her at risk for significant venous catastrophe. So Dr. Zuccarello actually said, hey, why don't we do a middle fossa approach? She already had preoperative facial palsy. So you can see on the upper right-hand side, the MRI scan shows the tumor that was removed. It left the lower cranial nerve schwannomas alone. The CT scan shows the amount of bone removal that was done. Bone overlying sigmoid sinus was left alone. And then after removing that, we also put an auditory brainstem implant. And so I think we're the first group, if not the only group, that has either 2 or 3 patients now where we've performed brainstem implants by a middle fossa approach. I think it's an interesting approach. The challenge, though, is you need it for special patients. So, for example, for her, since the 7th cranial nerve is going to be in the way as you do approach the lateral recess of the 4th ventricle, since she already had facial palsy, that wasn't going to be a problem for us. However, for patients who have functional facial nerves, this would be a challenge then to get rid of this or replace the ABI without injuring facial nerves. So I think there are clearly limitations to this approach. Now, I think we have more than 161 middle fossas by now. Probably my guess is close to 200, but this is still, as with any surgical approach to the skull base, you have significant potential risks of complications. We've had CSF leaks, TIAs, 1 epidural hematoma. Fortunately, no PE. We've had DVTs, wound infection, meningitis. So all these are, for all skull-based procedures, at a risk. Fortunately, no surgical mortality. So skull-based surgery, as we all know, is not for the faint of heart. That you'll learn from your mistakes, unfortunately, and they will occur. But you learn how to reduce that risk in future cases. This is our new center since Kumaresh was here. It's called the UC Gardner Neuroscience Institute. And this has been a wonderful new addition. So it allows neurosurgery, otolaryngology, neurology, physical medicine, and rehabilitation all to be in one institution and one building. So the hope it furthers our improvement of clinical care and allows us to do a better job with research as well as teaching. And that tripartite mission, having all 3 aspects, are very important for all of us to provide world-class care. And I have a video I can show, but I'm happy to open up to questions. But I want to finish with a quote by Sir William Osler. Medical education begins with the patient, continues with the patient, and ends with the patient. So we really owe a debt of gratitude to our patients. We've learned a lot from them, and they entrust their lives with us. And so it's important that we provide the best possible care. So I do have a video, but I will stop for right now and answer questions, but I'm happy to go to the video.
I think you can complete the video. We'll go to
okay.
And
will do.
The end, yeah.
Let me see here if I figure out a way. I'm going to stop sharing and see how I can also do it. Can you still see my screen, Prahlad, or no?
No. We see your family. Nice family. Yeah.
Yeah. Yes.
Okay.
Give me 1 second. I'm going to try to see how I can get this on here.
You have to share the application through which you're opening that video.
Yes.
Yeah.
Let me do that 1 second.
If it is a quick time, then you'll have to share the quick time.
Okay, so I'm now going to try, let's see, share. Prahlad, I don't know why it is not allowing me to share the screen. If you can do me a favor, maybe you can do it off your screen, because it will not allow me to share the YouTube video.
Okay. The video is on YouTube?
Yes, sir. It's on YouTube.
Yeah, okay, let me check it. So
Okay.
how do I search
So
for it?
if you do YouTube, Prahlad, and
Yeah,
then
yeah.
you do CI surgeon, standing for cochlear implant surgeon.
Yeah, CI surgeon. I'm searching CI surgeon.
That should be CI surgeon channel. And then there's a middle fossa on a facial nerve neuroma.
Okay. CI surgeon channel. I'm getting too many channels. Yeah. No.
So it should be all one word, cochlear implant surgeon, CI surgeon is what it should be.
Yeah, okay. CI surgeon. Okay. Yeah, now I see that. Okay.
Okay, and it should say middle cranial fossa facial nerve neuroma.
Middle superior canal, facial nerve neuroma. Yeah, we have it.
Yes,
Okay,
sir.
I'm going to share that.
Yes, sir. That's it.
Yeah. Okay. Let me share that. This thing, share screen. So I'll be snatching it back from you.
Yes, sir.
Sorry. Yeah. Okay, this is the one?
Yes, sir. That's it.
Okay.
So
It's
this
playing.
is one that Dr. Zuccarello and I did several years ago, and we had a wonderful student, Charles Poon was his name, and he spent about 15 hours per video. In fact, he actually is the first author on our paper. It was the first one discussing use of videos for teaching in otology, neurotology, for residency, for residents. So this is a patient who initially we thought it was an acoustic neuroma, but it's actually a facial nerve neuroma. And so we'll start the video in a second here, but this is just some of the images that Charles Poon had done. And so he's describing the anatomy on the middle cranial fossa floor and with the retractor in place. And you should be able to hear audio in a moment. I don't know if you can hear it or not. If not, I'm happy to still continue talking.
Yeah, we have the audio.
Okay. So left-hand side, you can see superior semicircular canal, intra-auditory canal. Okay. So even in the last few years, I think this video is probably 4 or 5 years old now. You know, you look at yourself and you say, how can you be better? I think even now in the last 5 years, I've realized that there's more bone that can be removed than what I've even removed here. So what I'm using here is a 2 millimeter diamond burr to decompress the labyrinthine segment of the facial nerve. You can actually see some of the cochlea, slightly darker bone, right where my suction is. And now I am working along the IAC anterior to the intra-auditory canal. So remember, the anterior portion of the IAC contains the facial nerve. So some people do not like the middle fossa floor or don't like middle fossa approach because you do risk injury to the facial nerve. It can be right underneath the dura, so you have to be very careful with the burr. I teach my fellows and residents both that the burr can be very slow. It does not have to be 75,000 RPM. That allows you to be less likely to injure the facial nerve. So that we are opening up posterior fossa dura here. And by allowing that to decompress, it gives us some increased ability to work. On this one, I think this video, I used to still keep the retractor blade after opening up the intra-auditory canal dura on the posterior fossa dura. Now I do remove the retractor blade just so I have an ability to work on the tumor easier. So this is our cochlear nerve action potential electrode. Unfortunately, this is not being made any longer. And I wish it was, because the CNAP electrode allows you to have a near field response. You have a much better response than you do with the ABR. Allows us improved hearing. So I did remove the retractor blade. As you can see here, that's just temporal lobe dura that's pulsating. Gel foam with thrombin is used there to cover up the IAC until we're ready to open it up and work on the tumor. What can be challenging for facial nerve neuromas is sometimes we do not know ahead of time until we are doing the case if it truly is a vestibular schwannoma versus facial nerve neuroma. But the nice thing is we will not have sacrificed hearing at all as we're doing this approach. So you can see nerves in the posterior fossa, and you can see the tumor. We're elevating the dura anteriorly. That is all the pale color of the tumor. And it's important to try to separate and expose this area. The PRAS probe is used I learned this from Dr. Zuccarello. He uses it not only for our identification of the facial nerve, but also for dissection. And it's actually a very good tool for dissection. I never had learned that before. And so it allows you to stimulate as you're working. So if you're not sure where you are and where the facial nerve is. So now you can look at the posterior fossa dura and you can see what maybe 7th nerve or 8th nerve and stimulate. So it gives you a sense of the anatomy at the proximal most end. And here Dr. Zuccarello is separating facial nerve from tumor. The labyrinthine segment is very important to me because if I know what labyrinthine segment is, I know what facial nerve is. Otherwise, when you're in the intra-auditory canal, you don't know what is facial nerve. You do not know if it's a facial nerve tumor or a vestibular schwannoma. We'll typically send these specimens off to the pathologist for both frozen section as well as permanent section all the majority of time. We should know ahead of time whether this is a benign lesion such as a schwannoma and not something malignant. So continue to work. Care is taken not to avulse the facial nerve inadvertently. Continue to debulk the tumor. The Sonopet, while we use that often for bone removal as well as for tumor removal, it can be a challenge to use in this area, in the IAC. It's too large, although the newer version, I've not tried it yet on the middle fossa approach. They have a new one that was released that may be smaller in size and easier to use in the IAC. Microinstruments are used in addition to the PRAS probe to sharply dissect tumor and sharply resect it. So as we're dissecting, we realized that this was a facial nerve neuroma and not a vestibular schwannoma. Then we place, if there's any changes in the AVR or CNAP, we place gel foam with the pavrin, and then take care of bleeding along the middle cranial fossa floor using flow seal or other hemostatic agents. We typically take temporalis muscle from, or a portion of the temporalis muscle to plug the IAC defect. Make sure there's no clot, significant amount of blood in the posterior fossa. Make sure there's good hemostasis. And that muscle graft, you realize, especially in a male patient, the temporalis muscle can be quite large. And so you can use that to occlude the middle fossa floor partially, as well as the IAC defect. And then I typically use temporalis fascia from the initial craniotomy. And then we'll use other dural substitutes, dural repair, durafoam, duraform, as much as other materials that are available. Some people have used alloderm. So I think there are 16 or 17 videos for anyone on this to learn other techniques for your residents or medical students. And I'd like to add more to that at some point in time. So thank you all for your time. I know it's already 10:50. Please let me know if any questions. I think there are some on the chat. So someone asked, what has been my experience with middle fossa approach for facial nerve decompression and Bell's palsy? I think is a wonderful approach for Bell's palsy. Although now the cases that I see that need or could benefit from middle fossa approach for Bell's palsy is less than they used to be 10, 15, 20 years ago. I've noticed our ER physicians and primary care doctors, our neurologists are much better at having patients get started on antivirals and steroids, so I don't have to do as many facial nerve decompressions as before. I actually, on Tuesday, just saw a patient with recurrent Bell's palsy. So for patients like her, I think she's a good candidate. So I will potentially set her up for Bell's palsy facial nerve decompression. So the size of the vestibular schwannoma, so when I look at size of tumors, even if someone has wonderful hearing, if the tumor is any larger than 2 centimeters, especially if there's a large CPA component. I don't think the middle fossa approach alone is good enough, although we have several patients that Dr. Andaluz and I have done, and the rest of our team, that have been combined middle fossa retrosigmoid. So if I have someone with excellent hearing and the tumor extends all the way to the fundus of the IAC, the retrosigmoid approach is not a good approach for that. But the retrosigmoid approach is clearly better, especially for larger CPA components. So it's not one versus the other, it's what's best for that individual patient. And then I see, do all patients with unilateral hearing loss undergo MRI screening? It depends. I tell patients, even if someone recovers from sudden hearing loss with steroids, I would tell them at some point in time to obtain an MRI with contrast. Some people will just use MRI without contrast and do Fiesta sequences because that can be typically cheaper. In the US, while most patients have insurance can be quite expensive, or healthcare be quite expensive in the US. From my understanding, in India, I know the number of people that are having insurance is growing, but a lot of patients have to pay out of pocket. So MRI scans, I'm sure, can be quite expensive. What extra precaution do you take when you use this approach for geriatric patients? So Ravi Shankar, great question. It's interesting. We just looked at our series, and Gavi Kohlberg, who just graduated from fellowship last year, he's at the University of Washington. We found no difference in complication rates between patients under the age of 65 and over the age of 65. And we use that term 65 with a number arbitrarily. I think that you have to be more careful of the dura. I have had patients where we've done the middle fossa approach into the patients that are in their 70s. Beyond that, I don't like doing it. If someone's in their 80s, I think they should just have another approach. I typically try not to operate on someone in their 80s unless they have a large tumor. We have seen that on occasion on patients in their 80s. And if it's something where you just want to debulk the CPA component and reduce pressure on the brainstem, I think the retrosigmoid approach is a faster approach for that. For dissection tips for preventing injury to superior canal, excuse me, I think the key is you have to spend time in the lab. You have to know the anatomy. You cannot do this in the operating room without having spent quite a bit of time in the lab. I probably now in the lab, I would say in my career, I've done this close to 20 years, I probably have performed 500 middle fossa approaches in the lab because I feel like I can always be a better surgeon. And I've learned from all my mistakes. I continue to make mistakes, unfortunately. But I think that is the challenge for skull-base surgery. So please, before you go to the OR to try to spend a lot of time in the lab. I know Ravi Shankar has told me that he's in Lucknow and he is working with neurosurgeons closely. And I've noticed that it has to be a neurosurgeon that's open to this approach and is willing to say, yes, I want to learn this approach with you. Because otherwise, if they don't like this approach, then this is not something that you can do. So learn how to blue line the superior canal, and doing that in the lab first is very important. And then learn where the ampulated end of the superior canal is. And if you do that in the lab, I think that helps you do a much better job in the operating room.
Yeah, I think some more questions. Bala sir, some more questions are there. One more question is there.
Thank you very much. Some more questions are there. I'm not able to see.
Yeah, that is Dr. Arulan Mathyalagan is asking, like, according to you, what is the contraindication to middle cranial fossa approach?
Yeah.
Larger tumors. If you're concerned, some people worry about the dominant temporal lobe. On a right-handed patient, that would be the left side. Some people do not like doing that because of risk of aphasia. There's certain anatomy. I think that we probably push the envelope sometimes a little bit too much. Sometimes I feel that I enjoy the approach so much that I have to remember I rely on my neurosurgeons to keep me sane and prevent from pushing this for every single approach. So sometimes I'll ask them what their thoughts are. And actually, Dr. Andaluz is right here. What do you think are good times when you say, besides tumor size, to say, no, don't do the middle fossa? And if there's any temporal lobe issues, seizure issues.
Yes, unless there's some scar from a previous operation.
He said scar from a previous operation.
Distort the anatomy a
Yeah.
little bit.
Distorted anatomy from prior surgery. We've never used it for post-radiated tumors because I don't think it's worth it. I think the translapidan approach is probably the best for radiosurgery failures for IAC and CPA tumors. Yes, so is there a special concern to collaborate with neurosurgeons? Actually, I'm going to turn that over to Dr. Andaluz because he's right here. He has been wonderful. He and Dr. Zuccarello have been wonderful to work with. So Dr. Andaluz, who's from Argentina, and I've worked with him for over a decade now. I can have him speak from the neurosurgical side. What do you think, Norberto, keeps neurosurgeons from saying, yes, we want to do this? So I'm going to introduce you, Dr. Andaluz.
I would like to see him. Yeah.
Well, thanks. Sorry for the impromptu. I think the only thing that I can say about working with neurotologists in my career is that they have only made me better. I have learned different ways to approach things, not only from the surgical standpoint, but also from the thought process. And I've learned to respect things that I used to be not so attentive to, and I'm really humbled by how much detail to the technique and the attention to the details on the preservation of the nerves and details on anatomy and some of the other things that we do surgically without much regard that have a significant implication in patient outcome and function. The research part, that's something that I work with Dr. Samy, Dr. Pensac through the years, and some of my colleagues, also has been mutually empowering, I would say, because we have dared to go to places where we as neurosurgeons were afraid of going, and vice versa. I think the same is for Ravi. I mean, the way I see him now manipulate an instrument around the brainstem at the origin of the facial nerve, I haven't seen many neurosurgeons do that with such skill. And I'm sure that he's doing that because he has seen us doing it, and, and you know, he knows where to go, where not to go. And for me, it's exactly the same. I know I have become a much better surgeon and a much better doctor in general, thanks to Ravi.
Yeah.
What do you think keeps neurosurgeons from embracing mental fossa? Why do you think it's not more widely accepted?
Why? Because it has many nuances. It is not a simple approach. You know, we neurosurgeons do a lot of subtemporal approaches for a number of conditions, tumors and vascular malformations and so forth. But it's a very challenging surgery. And for some people also the situation of not having the luxury of having a skilled neurotologist to help you with your middle fossa cases is a main limitation.
Yeah.
Many neurosurgeons are very comfortable with doing posterior fossa approaches. Yeah. And that also applies for other things that could be treated, some other tumors that could be treated with combined middle fossa or transpetrosal approaches that we use a lot with our friends here in Otology. They're not done just because of lack of exposure or lack of education, but it requires you to have the open mind and the ability to modify your culture towards better patient outcome and mutual improvement.
It's interesting. Norberto said something that's so true. Like, I've noticed him and Dr. Zuccarello, who used to be chair, and is still a professor here, and is my mentor and Dr. Andaluz's mentor. They both are actually cerebrovascular surgeons in training, and their ability to feel comfortable around a loop of ICA, around cerebrovascular anatomy. And Dr. Zuccarello said this to me, and I truly believe this. Like, he said that cerebrovascular surgeons, neurosurgeons, make some of the best tumor surgeons, that they don't have a fear of vessels. And I would say that's probably also true with otologists versus neurotologists. What I've noticed is I have some colleagues who are amazing otologists. They do better stapes surgeries than I do. They do better mastoids and panoplasties than I do. And I still feel like I can be better in those areas. I've seen Prahlad, and some of the work that he's done is amazing. And I think what's neat about India is the ability to do that quickly at lower cost than typically we do in the West. But the otologist, if someone's not doing neurotology, I tend to see that they are fearful of dura. They're fearful of CSF leak, whereas that is a part of neurotology. So I think that, finding a cerebrovascular surgeon for Ravi Shankar, for example, if he wants to adopt this in India, and I've said this before, we'll have to do this in the post-COVID era, of course, but I would love for Dr. Andrews and I come out to Lucknow and do a middle fossa approach or other parts of India. I think that's what makes this fun, is we can improve the quality of care for people throughout the world. And I think for all the negatives that is COVID, one of the positives is that we can all learn from each other without leaving our home. We can still go home and have dinner with our families at night and not having traveled around the world. So it's wonderful. Some other questions I see here. I still do the middle fossa approach for vestibular nerve section. I think it's a wonderful approach for that because I can see the eighth nerve separating into different fibers much easier, but that I know there are other docs that do retrolabyrinthine, retrosigmoid. Some will actually do a translabyrinthine vestibular nerve section if the hearing is already significantly impaired. I do preoperative ABR, and unfortunately, I cannot guarantee, of course, that we can save hearing with this approach for our IAC CPA tumors, acoustics in particular. But the better the preoperative hearing, better the ABR preoperatively, the better the chance of this. And the final question is discuss advantages and disadvantages. I think what we are struggling with as surgeons of the skull base is, especially in the US, we're seeing more and more radiosurgery being done, and the outcomes of radiosurgery can be fantastic. And I don't think that's necessarily bad. I think it makes me say, I have to be a better surgeon. I have to get better outcomes, because otherwise, why not just do radiosurgery for smaller tumors? So I think that it's got to be the right individual, tailor the right approach for the pathology. So, and in fact, I've got to go now to the operating room. Dr. Andrews and I have an acoustic, but not middle fossa, it's translabyrinthine today. So I apologize. Please feel free to email me. I'm sorry that I have to leave, but I do appreciate it.
Dr. Bala, you can summarize this.
Yeah. Thank you very much, Dr. Ravi,
Thank you, sir.
for a fantastic talk on middle cranial fossa approach.
Thank
and
you, sir.
you've shown us that this is a very good approach, versatile approach for various pathologies of the skull base, including
Yes, sir.
early acoustic neuromas, aneurysms, petroclival lesions, or including postcranial fossa. That's a very difficult approach, I think, because a lot of complex anatomy here. We need to identify the greater superficial petrosal nerve, lesser petrosal nerve. It's a very small nerves, and always done under microscope. Do you have any, so do you use endoscopes? While
I
doing
have. It's a challenge because if you look at the intra-auditory canal from above, I've used it the most for retrosigmoid approaches, because if the tumor goes beyond mid portion of the IAC, I have concerns about leaving tumor in the fundus. So I think it is helpful. I have used a middle fossa approach, but it's sometimes a challenge because there's not a lot of space. You're risking still heat injury from the endoscope. You're risking movement that can disrupt 7th and 8th nerves. You have to know where ICA is. So yes, I've used it, and I think it's something that my skill set can improve with. So I think that's a great question to bring up. Absolutely. Yes, sir. You're absolutely right. Thank you again. I appreciate your time.
Yeah. Thank you all. Thank you very much.
Thank you.
There are two great take-home messages today. One is possibilities of middle cranial fossa approach, and the second most important is teamwork with neurosurgeons. Thank you, Ravi.
Yeah, Thank you.
Have you back again soon with us.
Oh, I'd love to. Absolutely. Yes, sir.
Yeah, maybe if your Friday is your OR day, definitely we can have another day. Yeah. Thank you very much.
Thank you so much.
Most welcome. Most welcome. Thank you, Dr. Bala, and also thank you, Dr. Kumaresh. I muted him because the microphone was making too much noise. Yeah. Thank you all. Thank you. Thank you very much. Yeah.